I'm very excited that our next speaker is doing his best to join us today. He's currently in his home country of Pakistan, which is a country experiencing many challenges at this very moment. So we really appreciate him putting in the effort. Dr. Wahab is a psychiatrist at Shifa International Hospital in Islamabad, Pakistan. And again, I believe his work supporting the needs of displaced Afghani youth makes him a great source of insight into the challenges faced by people providing healthcare into displaced persons. Dr. Wahab, thank you so much for doing what you can to join us today.
Thanks a lot, Scott. Thank you so very much. So the topic of presentation is lesson learned working with displaced youth. It's been a long journey working with displaced people, almost more than 15 years. So it's a hospital where I work. It's called Shifa International Hospital. It's situated in capital city of Pakistan. In the background, we can see the mountains called Margala Hills National Park. My presentation outline will go like we first briefly discuss objective, then go to introduction, then what's the magnitude of problem, and what is the provider network available to us to face the challenges. Current situation in Pakistan, the context of displacement, and its possible impact in the form of looming mental health challenges. Lastly, the lesson learned working with displaced youth and what the possible way forward to address the issues. So at the end of the session, participants should know various dimensions of human displacement, including psychosocial consequences and possible intervention to ward off them. An overview of the displacement in low resource setting like Afghanistan and Pakistan, and a brief outline about the current catastrophe, that is flooding in Pakistan. And as a consequence of that, looming mental health we expect. So briefly want to share my experience with you guys in Afghanistan. In addition to working in person, various settings in Afghanistan, is part of WHO team and other international NGO team, been also part of e-health project, working in the farthest remote in the northern part of Afghanistan, that is called Badakhshan province. And that was an exciting experience. This project funded by Grand Challenges Canada. And I was the technical advisor using mobile health and e-health, keeping in the very low bandwidth of that area. And just to share with you that the area of Badakhshan province of Afghanistan is very interesting geographical spot. This is on the Wakhan border, shared border with there's on the northern side, there's Tajikistan, China, in Pakistan and Afghanistan. So 4 countries converged there in that spot. That was one of the intervention area for us to work there. And that project lasted for 4 years. So we learned a lot of lessons using very innovative strategies like mobile health and telemedicine and telepsychiatry and e-health interventions. So the design and implement evaluation sustainable and scalable project, and it was formally adopted by Afghan government. The project lasted for 4 years from 2010 up till 2014. So let's just focusing on the magnitude of the problem, we can say that globally, as mentioned previous presentation by Dr. Khan and others, that almost 90 million people they are that have been displaced for one reason or the other. More than 50 million internally displaced person worldwide, 27.1 million refugees. There's an interesting dimension of IDPs and refugees, because IDPs, they differ in terms of their human rights and other resource availability as opposed to IDPs. But there are certain bindings rules delineated by World Health Organization, United Nations, to be adopted by the government where IDPs live. Very interestingly, more than 40% children and young people between below 17 years of age, they are part of the displaced people. Situation in Afghanistan, according to the HealthNet TPO, which is a Dutch NGO, and I had been part of this NGO for almost 7 years in Afghanistan, involved in training general practitioner there, and also other health professional like health workers. Almost half of the population of Afghanistan are suffering from psychological distress, with decade of war resulting in widespread displacement and psychosocial turmoil. Almost 45% of people, they have been internally displaced, and more than 3 million out of them, they live in neighboring countries, including Pakistan. So the ongoing crisis is still continuing. With the latest unfolding events, we can see surge of refugees in the neighboring country of Afghanistan as a result of recent event like takeover of power by Taliban regime very recently. A lot of challenges and meager resources available to them. So it's a very unending and continuous problem Afghan people are facing. Pakistan's interesting country with interesting geography and interesting situation. We host our 1.2 million refugees over the last 2-3 decades, but these figures are official. Many more are unrecorded, and according to few estimates, the number of refugees probably double this figure. Now, almost 90.9 million IDPs as a result of various conflict in Afghanistan, neighboring part of Pakistan called FATA, federally administered tribal areas, and other part of Pakistan. And about 0.2 million they are asylum seekers, mainly from Afghanistan, Iran, and some other countries. Up till now, according to some sources, and as a result of the latest events, 1.6 million refugees they live in Afghanistan, and many are still coming, and they are taking refuge in Pakistan as a result of new regime in place in Afghanistan. So refugees IDP crisis is very painful. It's part of one of the studies, and according to that study, almost 99.7% of the internally displaced women, they score above the threshold for psychiatric morbidity. And this study was a large-scale study in Peshawar, capturing population of IDPs from various parts of northern Pakistan. Every one of them considered to be suffering from psychological, almost. Their human rights violation of mammoth, and extremely staggering. Unfortunately, the refugee status not implemented as far IDP status concerned, but United Nations guiding principle anti displacement were also not being followed in this study. This was in another study exploring the phenomenon of suicidal behavior in the aftermath of displacement from Malakand division, which is another very farthest part of Pakistan, rural part of Pakistan. As a result of Taliban insurgency there, about 3 million people, they were displaced, and they were scattered throughout Pakistan, and their displacement was very unique. keeping in view the unique security system. So right after that, you can see in 2013, the suicidal behavior just almost less than 100 in those areas, surged to more than 350 in first quarter of 2018. So a lot of, and this was a mixed methods study with the qualitative arm. So we had a lot of in-depth interviews with stakeholders, and we should looking at the conclusion that most of them, they were traumatized with the process of displacement. Now, keeping in view the huge burden, the provided network available to us is very, very weak, I can say. The scarcity of mental health care professional, dearth of meaningful research initiative, lack of data to inform policy, and lack of meaningful international collaboration in service development and in the area of research. Now, current situation is very is painful. You all know being covered by almost 1/3 of Pakistan is right now submerged, and more than 40 million people they have been displaced so far due to current flooding, and this is a looming mental health crisis, I must say, because keeping in view the resources available to us, and then thinking about the aftermath of the situation is frightening. The National Disaster Management Authority of Pakistan reported 39 people so far displaced, and out of them 6 million are pregnant women and 2/3 are children. So you can very well imagine the magnitude of problem we are facing right now. And these people were called displaced people, and they are in the face of extremely meager resources available to us to cater their needs, psychological, physical, and social needs. Now, possible in the background of displacement, the possible psychiatric impact is very, very important to look at. We know the pre-migration time is not, the migration or the displacement is not itself a moment, an immediate moment, but there is a background to that always. And there's background keep on affecting the social fabric and other areas, including many social factors. So all those factors predispose people biologically, psychologically, and socially. So many of the people who are in the phase of pre-migration, they are already prone to have psychiatric problem. Now, the migration process itself is a transit period in terms of a triggering factor, triggering a lot of psychosocial issues, including psychiatric problems itself, and then post-migration problem. Until the when we are supposed to deal with issues like psychiatric disorder itself, and trying to meet the challenges of that. Those few lessons I want to share with you. The radicalization of displaced youth is a very important phenomenon because they are under a lot of stress, and when there are a lot of stress and they are supposed to deal with that stress, they are a very fertile ground to be exploited by various factors, including political radical factors, religious radical factors, and social radical factors. So the displaced community is always a fertile community for especially for the youth to be radicalized in that way, and then they become problem for themselves and they keep suffering, and they are also source of problem for others in that community. There is widespread abuse which has been reported in very previous literature very frequently in this community, lack of political will, because is one very important lesson we learn while studying displaced people, and the lack of equity in public services, stigma and barriers. And this is primarily because we are unable to understand the cultural and social values of people. So, and their point of view, looking at mental and social issues. In the suicidal behavior, a lot of literature point toward that is very common. People who are displaced, who live uh, uh, in despair with very little social and psychological energy to deal with stressors, and very prone to develop the upstream factor for suicidal behavior. But many more, they don't fit into a definite psychiatric diagnosis. So a lot of complex psychological condition, we're unable to fit them in any diagnostic category, is again very common in displaced population. Now, how to be curious for there's a big challenge for us, for mental health, for social worker, for psychologists to deal with them, understand trauma, because trauma, it's a bookish picture of trauma is different many times while working in situation where there are, cultural issues, social issues, and social and cultural backgrounds as well. And now recognition of the resilience is an important thing. We have to work on resiliency to understand and to build on that and to make that population less vulnerable to develop long-standing, long-lasting consequences. So the way forward to help displaced populations, culturally sensitive approach is needed, because many a time we do research, we capture data, but we don't use validated instrument to understand and to gather data, and then present that data in a meaningful way to represent the displaced population. This has been happening everywhere around the world. Maybe people then facing that problem in people who've been displaced in Ukraine or Afghanistan and Pakistan. And they'll be thinking of a specific culture, a specific culturally sensitive tool to apply that and capture the data in their representative data. Now, we've been failing miserably to come up with tailor-made approaches to deal with the population and to come up with the guideline applicable to all the displaced people. We have not been able to take them into confidence and make them part of the decision making. Not been able to sensitize the healthcare system to deal with the possible racist tendencies. I've seen this in Afghanistan, I've seen this in Pakistan, that the racist tendencies and this human, kind of aversive instinct towards people who've been displaced is sometimes a big issue to deliver and to come up with culturally sensitive intervention. Now, how to integrate them into community is again a big challenge. We have not been able to integrate Afghan in Pakistani population so far, even after 30 years of their status as refugees in Pakistan. And this is a big challenge. I think this challenge is very common to every community around the globe, be it in the United States or Europe or anywhere else. How to integrate them. Maybe we need to come up with kind of innovative approaches and innovative solution and innovative intervention to make them effective part of the community they live in. Now, brief, you can very well imagine the gravity of displacement, and then follow up. You're facing the issue with the current challenges in Pakistan, but not being able to come up with the solid guideline. We're still using, either DSM or ICD or some tools or some research intervention, primarily made for developed countries to capture the data. We have yet to come up with the indigenous models to deal with the problem. Now that's it. Thank you very much.
Dr. Wahab, thank you so much for that. So we got a bunch of questions for you. I'll start with, I know personally there's a lot of different or several different types of schools in Pakistan, the public, private, etc. Since so many youth are affected, are there any programs in the schools to help support young people? And if so, what do they look like?
I think this is a very interesting question, Scott, and thank you very much for asking this question. School system in Pakistan is unique in the sense that we haven't been able to come up with a uniform syllabus. We have not been able to come up with a national representative curriculum either. We have madrasa school where they're purely religious kind of education available to students, and they are almost 1/3 of the total population. Then we have government public run school where you go to public sector schools with different syllabus, different curriculum, and then we have schools for people who can afford. They are called private schools, and they follow the Oxford or Cambridge model. So first, most important thing for us to come up with a uniform model. Now, if you visit a student in madrasa and ask him about creativity or his attitude toward creativity, you will find that 180% in contrast with someone who goes to a private school. Secondly, the most important point I should share with you is the issue of corporal punishment, which is I mean highly prevalent, and we have been looking at that this issue in collaboration with Dr. Khan. There are interesting findings, and this corporal punishment is more prevalent in madrasas, where 1/3 of our children they go to graduation. So these are practical issues, practical problems. And let me share this with very painful information with you that for people who've been displaced or who live as refugees, for example, Afghan refugees, almost 60% of them, they don't have access to schools. And this is very, very painful, fact. And this data is, not from this, but this is Afghan refugees departed in Pakistan. According to 60% of them, as a result of that, very high proportion of them, they are involved in child labor, and they're being exposed to, and they're vulnerable to a lot of abuses, including physical, sexual, psychological abuse. So this is a big issue you're facing right now.
One of the things you mentioned, we're talking, we know young people are generally fairly resilient, but you mentioned working with young people who have experienced, one or more traumas. Do you find that they tend to be as resilient as young people who have not necessarily experienced traumas, or do you think there's an impact there?
Generally, there is kind of reversal as far vulnerability of population segment to psychiatric problems in Pakistan. For example, let me just share this very interesting finding with you that there is a gender reversal in suicidal behavior. Now, more women they have suicidal behavior in Pakistan, according to our latest data, than men, and this is in contrast with Western, studies. Similarly, we have data, and we recently published data as well, that suicidal behavior and vulnerability of the younger population is much higher than older. Almost less than 18 years of age group, they are 3 times more likely to indulge in suicidal behavior. And on top of that, they are more vulnerable to be radicalized in a way, to become part of some, some cultic behavior or cultic activity. Either they go to the religious cultish because they are more impressionable. They have a lot of energy. So this very complex kind of situation going on with young people population, and in addition, top of that, we don't have resources to deal with that.
Thank you. You mentioned before that the UN's guiding principle on internal displacement was not followed. Would you be able to elaborate on that just a little bit?
Yeah, we have, there are 2 sets of principles supposedly addressing issues of people who live, as either as refugees or internally displaced persons. But UNHCR doesn't recognize IDPs, the internally displaced persons, as refugees. So they don't get the total set of privileges, or the total privileges a refugee should get. But the guiding principle is also not sufficient. The UN guiding principle to address needs is totally insufficient. It's totally based on some NGO work, non-government organization work, or some international NGOs with scarcity of resources available to them. But international community as such, in a lot of international convention, they don't recognize them as refugees, though it's a huge, huge problem for us in Pakistan.
One of the questions that was asked a little earlier was that when working with a family from Afghanistan, someone said that the family did not seem to have a good understanding of mental health, emotional pain, or trauma. It seems like a foreign concept to them. Is that the kind of thing that you would that you've typically encountered when working with folks in the region?
Yeah, this is again very interesting question. To my mind, because I've been working with HealthNet TPO for a long time and had chance to visit various Afghanistan cultural settings, including now a large part of the. To my understanding, they are more insightful into psychological problem. And they have, and that primarily because of the efforts undertaken by previous government, because they recognize mental health as a primary focus. And they were able to sensitize international community to come up with the efforts to address this issue. So that effort of previous regime, when they recognize mental health problem as a primary issue of Afghan people, made a huge difference. But yes, you are right. There are a lot of cultural and traditional taboos which bar people from seeking help, and stigma associated with lot of local. But as a government, Afghan government still recognize mental health as a primary focus. But over last in the last regime, I think they spent huge resources, and they attract a lot of attention and international donor, international people to highlight mental health issues of Afghanistan.
All right, Dr. Wahab, thank you so very much for your time today. I really appreciate it.
Thanks a lot. Thank you very much.